You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. Hey, hello, everybody. So this is going to be, I don't really even know. I'm not tracking episodes anymore because I realized that last year when I was doing this, I was calling episode 14 like episode 12 and the other way around. So I don't really know, but I'm excited for this episode because this is the first time that we're actually going to sit and just talk about a clinical topic and clinical cases. So I have with me today probably all of you that have done any sort of coursework with Redefined Health Education have at some point engaged with Jessica Klain. She is my outreach assistant. She's really more like a strategy slash outreach slash like all
social
of the
media guru,
like social media guru slash my sounding board for everything. So assistant really isn't the right term, but yeah, today we're going to talk about a case of transient global amnesia. And I think this is important for every physical therapist and every clinician to hear because if you saw something like this, you might automatically assume that somebody's having a stroke, which is what both me and Jessica would have thought. But there are some nuances here. So Jess, why don't you tell us about your case?
Absolutely. So a little bit of background. I am a physical therapist and I work in Denver, Colorado. I have my own solo practice and I rent a space or a private treatment room out of a gym. So I have a really great relationship with a lot of the gym members, including this one. And I did get permission to share some details about this patient. So this gal is a 59-year-old female. Her name is Kelly. I have not seen her as a patient, but I know her professionally. She's a psychologist in town and just really calm, nice, sweet person. And I know a little bit about her workouts. She never does anything crazy. She's not doing Olympic lifting. She's not practicing Valsalva maneuver, but she is legit working out in the gym, lifting some heavy weights. So around 12 p.m. a couple of weeks ago, she stops me in the gym and she says, "Hey, I'm feeling a little strange. Like there's a little like blip in my day." And she uses that word blip about 36 times in the next 20 minutes, which is why I think it's so important to include that specific phrase. And so at first, nothing was strange. Her affect was totally normal. She was extremely calm. And I just keep talking to her like, why aren't you feeling well? Do you need to be, have a snack, low blood glucose? Have you been hydrating? It's really hot today. How'd you sleep last night? How'd your workout go? And she answers all those questions pretty normally. And then 90 seconds later, she says, I feel like I had a little blip in my day. And that same exact tone, like it was brand new information to both of us. Mm-hmm. So at that point, I'm like, I'm going to take your blood pressure, just kind of hang out with you for a little bit. And her blood pressure was pretty high. It was about 190 over 100. So high, not alarmingly high, like we have to do something ASAP. Mm-hmm. At this point, I'm observing her, right? Like no droopy side of her face. Like she's moving very normally. Her speech isn't slurred. Both of her pupils are normal. So all these passive observations that I'm still thinking, is something wrong or is something not wrong? Mm-hmm. And then she says, "Oh, there's a blip again." I'm like, okay, this is the third time in about 2 to 3 minutes, which is kind of weird. So then I asked, "Hey, what day is it?" She had no idea. And she couldn't even come up with an estimate. Sometimes we don't know what day it is, but it's very different when you say, is it Tuesday or Wednesday? Versus, I have no idea. Right. So then I asked who the president was. And that's when she got a little upset because she could not think of who the president was. And she didn't even have a guess. And you could see her getting emotional because she knew that she should know that answer. And she didn't. And she couldn't come up with anything reasonable. So she starts getting emotional and she's asking me, what is going on? Like, what is wrong with me? And I say, hey, this is what's happened so far. I'm concerned because you don't know what day it is and you keep repeating the same thing, and I'm going to have to call 911. And she's like, okay, and is a little bit emotional about it. And as we're getting situated, I can tell all of a sudden she's not emotional anymore. And I realize it's not because of anything that I said, it's that she has forgotten what we just talked about. Like, she was a blank slate again, which was just so bizarre. So as I'm dialing 911 and I'm on hold with them, unfortunately, another gym member walks in. Yes. So total sidebar conversation about Denver, Colorado.
What?
I was probably on hold for about 3 or 4 minutes in this case. 6 months ago, I was in a car accident and I was actually on hold for about 12 minutes. Thankfully, nothing terrible was happening, but they didn't know that when I called. So
I've never heard of this.
Yeah,
is this like a Denver Metro thing or what?
I know I'm 2 for 2 for being on hold. And so this time I was like, oh, at least it wasn't that long.
Oh my, okay. Well,
yes.
yeah.
So don't have an emergency in Denver.
Oh my gosh. Okay. All right. Go ahead. Go on. So you call 911, you're on hold, and
so I call 911 and I'm on hold. And at this time, another gym member walks through the door who I know is a nurse at a local hospital. So I was super relieved that I had another person to be an observer in case something was happening, because the only thing that I can think of in my mind associated with these short-term memory problems Kelly's having is that she's having a stroke or at least a TIA. And I'm like, to have an extra set of hands if something crazy happens is really important, and somebody who has a lot of training. So this other gym member, Chris, did a really excellent job of taking over. He was super calm, asked all the questions. He retook her blood pressure. It was still extremely high. I could see out of the corner of my eye. He went through his whole stroke protocol as well, and nothing significant was coming up. When I finally talked to the 911 operator, she had me go through all the stroke protocol as well, which included have her smile, does it look uneven, have her raise her arms out in 90 degrees flexion, can she hold them up? So all of that was completely normal. And the other interesting thing at this time is, although Kelly had a short-term memory of about 90 seconds, other than that, she was totally normal. All of her interactions, she could answer what year she was born, her full name, who her partner is, and her demeanor, her affect was just completely normal. So paramedics came, they were great. They went through the whole stroke protocol again. Nothing outrageous came up. The same questions kept coming of like, what's happening? There was a blip in my day. And so the paramedics were here long enough to probably get another 5 rounds of questions of, oh, what's happening? What's going on? So a funny comment, as Kelly was being wheeled out on the stretcher, she looks at her feet and goes, why am I wearing Birkenstocks at the gym? And I'm like, that's a great question. Why are you wearing Birkenstocks at the gym? So then there was this whole question of, did this episode start before she got to the gym, which was about an hour to an hour and a half prior to when she stopped me at about 1 p.m. So as I've looked back into how things went through the day, we don't know when her memory started going, because she was able to physically drive herself to the gym.
Right.
So about an hour later, I get a call from her partner who had gotten information from the hospital, and it was a negative CT scan. Eventually, they did do an MRI, which was also negative. They did a drug test, which was negative. And what she was diagnosed with was transient global amnesia, something that I had never heard of before. But when Katie and I started talking about it last week, when I told her about this interesting story, she had indicated she had never heard of it, but also had a case or an interaction with somebody who was diagnosed with transient global anemia recently, right?
Right. So yeah, it was the craziest thing because when you brought this up, you were like, oh, because we were talking about other things like business stuff. And then you were like, oh, I had this case, this weird situation happen last week. And then you went and told the story. And I was like, oh my gosh, I had a new patient like 2 weeks ago at this point, who had this in his medical history. And he brought it up, and I had never actually heard of it before. But when he brought it up, I was like, you know what? I could see that happening, and I would be terrified. And, his wife was terrified at the time because he just kind of totally lost his like sense of right now for, I don't know, it was probably a good 30 or 40 minutes before she decided to like take him to the hospital. And how scary for probably the individual that it's happening to can't get a grasp on how scary that way. It's not like breaking your leg. It's not like physically having a heart attack or having, worst thunderclap headache of your life. This is like something where it's happening and you don't even necessarily know that it's happening because you're having amnesia. So when you said that, I was like, yeah, this is crazy. And then we decided to do a podcast episode about it. So I think right now is probably a good time I pulled up this article that actually has just a really nice overview, and it actually has some good differential diagnosis criteria, some algorithms for assessment and management. And this is by Seeley and colleagues. I'll put it in the show notes. It is a 2022 paper that is just a really, really nice overview. And the things I thought that the key here, because the two things that I would be interested in knowing is at the time, like in your situation, when you were witnessing somebody actively having this, first of all, like, what is this? And it seems like a stroke, probably first thing that you're thinking of, like the scariest thing that could possibly happen. And that's, not uncommon when somebody's having a CVA or a TIA. And so like, is this happening? And do I need to call an ambulance like right now? And this paper does a really nice job of outlining the things to look for. But I'm still battling, okay, even if somebody is having this and they're in front of me, I don't know how long it's going to last. They don't know how long it's going to last. What could they potentially do to harm themselves in this time period when this episode is taking place? So in my opinion, acutely, while it's still happening, it seems emergent to me. I don't know. What do you think?
I completely agree. Knowing what I know now about transient global amnesia, and the article that Katie is referring to basically says if all signs point to transient global amnesia, there's really nothing to do unless maybe the memory doesn't come back within about 6 hours. Mm-hmm. 6 hours is a long time to wait when you don't know what's happening. Mm-hmm. So in the situation that I was in, where I kind of know this person, but I at the time didn't know anything about their medical history, I don't think I could risk not calling 911 because the alternative diagnosis of it being a stroke or even a TIA, I personally don't think it's worth the risk of this wait and see mindset. Now, in hindsight, after reading this article, Kelly fits almost every single criteria of this transient global amnesia, where she's 59, so she fits into that 40 to 60-year-old category. She's a female. I did find out after the fact that she does have high cholesterol that she is not on medications for. And this is the real kicker. She had an episode of exactly like this 6 years ago. Which at the time, obviously, I didn't know that. And I'm not even sure if she was my patient, if that would have come up in a routine medical history. That might be something that we would have had to dig out in a very thorough medical history if she was just seeing me for an ankle sprain.
Yeah, yeah. So this is why I'm a huge fan, and it can be done quickly and efficiently, but I'm a huge fan of every patient, every time, no matter what, you knew their medical history, in and out. You're asking all of those questions about global systemic things that have been in their medical history so that even though they're seeing you for an ankle sprain, you have a good awareness of what their risk factors are. So if they have some type of event in your care while you're, face to face with them, or while they're just, you're managing them for a particular issue, you got to know this stuff. And it's important. And that's how it came up with my patient, because I do a very thorough review of medical history. And this patient just marked yes. You know how these intake forms work, right? So, like, I have the luxury of being in my own practice. My evaluations are 90 minutes generally, sometimes 60 minutes if I know someone before and I'm comfortable with doing a 60-minute evaluation, then I'll do that. But most of the time, if I'm seeing a patient for the first time, I see them for 90 minutes. If we use the full time, great. If we don't use a full time, great. But that's how it came up with this guy. He had marked yes to neurologic disease or neurologic condition in his medical history. Then it's our responsibility to follow that up. Okay, you marked yes to this. Why did you mark yes to that? And then he was like, yeah, I had an episode of this. It took less than 30 seconds for him to explain the episode and for me to sort of check the box of this isn't a current thing. But he did say that he was going to that he still sees a neurologist because they're working him up for this potential, which is one of the differentials, and I want to talk about that. This potential transient epileptic amnesia, so like a sort of a seizure related component to it, because his original diagnosis was transient global amnesia, which really is pretty. For everything that I'm reading from this article, it's basically like you have some sort of again, transient, so time limited issue with like the venous drainage of the hippocampus, where we have our short-term memory function. And for some reason, it just happens to some people. And the risk factors that are associated with transient global amnesia are not at all related to the risk factors for CVA. So like major risk factors for stroke or TIA, we're talking those patients with all your cardiovascular risk factors, your, obesity, hypertension, high cholesterol, diabetes, all of the things that you would think would affect the cardiovascular system, which we know CVA is a cardiovascular, cerebrovascular accident. But in these other cases, so the other differential diagnoses from this paper, we obviously have the most major one, CVA, TIA. Then migraine headache was number 2 on the list. Transient epileptic amnesia, which there's a seizure component to that, but it wouldn't necessarily, my understanding after reading this is that it wouldn't necessarily be super apparent right away compared to transient global amnesia. And then, of course, there's vertebrobasilar insufficiency. But that, if you had the vertebrobasilar insufficiency, if you had a CVA, and even sometimes the migraine headache, you'll probably have some cranial nerve errors. You're going to have, and with the migraine headache, they usually do have some sort of visual change, which sometimes can even be as bad as blindness, like temporary focal, whether it's central or peripheral blindness. I've actually heard of that. So any comments on that, on the other differentials, and why we would think, okay, this is probably not as big of a deal as a stroke right off the bat? What are the key characteristics there?
Right. So, I mean, differential diagnosis, like I said, I think in that moment, it's really hard to convince yourself that this person is at zero risk for a stroke and nothing needs to be done. We have those criteria of BFAST for the stroke component that we can observe. And although I, didn't specifically go through every single letter of BFAST, I'm like, man, this doesn't look like a stroke, but I don't know what else it can be.
Mm-hmm.
And
But she had the super high blood pressure
She
too.
did have high blood pressure,
Yeah.
yes, but
Mhm.
her balance was good. She wasn't complaining of eyesight changes. There was no
Mhm.
face drooping. She could hold her arms up. She wasn't complaining of any weakness. Her
Mhm.
speech was totally normal. I still decided it was time to call 911
Yeah.
from a differential perspective.
Mhm.
But as you're saying with your gentleman who's following up with neurology for potentially an epileptic side of this, my patient is following up not with a neurologist because the ER told her she didn't need to. She chose to follow up with her primary care, which I was fully on board with. And her primary care is chasing potentially, she's not diabetic in the traditional standpoint, but she is currently wearing a constant glucose monitor to see if
Mhm.
maybe there's something going on with that. And
Uh-huh.
so TBD on those results. But I think there's a difference between what this article is suggesting and saying, hey, you don't even need an MRI or a CT scan if your memory comes back after 6 hours. Basically, you're fine. This is totally benign. But both of our patients, there's still maybe
Mhm.
something underlying that is causing this, or potentially could be a preventative measure to prevent something else.
Yeah. So, okay, so let's come back and actually talk about the algorithm because we haven't even really talked about that. So there is an algorithm in this paper. I actually really this paper is great. It's very simple. It's written for clinicians, which is the types of papers that I like to read. This is an algorithm for evaluating sudden onset anterograde amnesia. So if you identify that a patient has this, the very first thing that you're going to do is do a neuro exam. Okay, so you're going to do your cranial nerve exam. You're going to go through the BFAST, which let's review that for people who just need a quick review. So BFAST, that's that um, uh, the acronym for assessing for stroke, and it's advertised. In fact, we went to well, okay. So another fun fact: Jessica and I are both from Western New York. I'm originally from just like the north side of Buffalo. She's from the south side of Buffalo. And I was home visiting family in July, and we went to a Bisons game. Buffalo Bisons is like a minor league baseball team. I used to go to these Bisons game all the time as a kid. When we were at the Bisons games, they had advertised. Buffalo General Hospital had all these T-shirts and stuff for Strike Out Stroke. They have this big campaign going on, and it had Be Fast across all of the back of the T-shirts. Now my boys wear these T-shirts because they select one T-shirt that they like to wear and then they just keep wearing it. My husband is the same way. So now I have Be Fast definitely stuck in my head. But for those of you who need a little refresher, the letters stand. So B is for balance. So obviously assessing if they have any acute balance deficits in one side or the other, if they're walking funny, ataxic gait, something like that. Looking at their E is for eyes. So checking for vision loss, pupillary constriction or dilation. The changes in peripheral vision or central vision is a big one, especially for stroke. Face, so looking for that uneven smile, and you can go through these real quick. That's why I like the acronyms really nice, Be Fast. So F is for face, A is for arm. So basically with this, you just have them raise both arms to a level, either straight out front or out to the side, and see if there's any significant change in the speed at which they're doing that, or if they're even able to do that at all on one side. Looking, S is for speech. So looking for that slurred speech. I think there was a really famous episode of this that was actually televised. There was a broadcaster or a reporter who was reporting, and then she was in the middle of reporting and just started totally making like speaking nonsense, and she was actively having a stroke in front of the camera. So be on the lookout for that. And then T is time. So if you identify these things, call 911 because the person's probably having a stroke. And the faster that we can identify those things, and the more the quicker they can receive care, the less likely their deficits are going to be. So be fast, like be very fast. Maybe there should be a very in there somewhere. But so the very first, so coming back to this paper, if you've got sudden onset anterograde amnesia, we're doing our neuro exam, going through the whole Be Fast criteria, assessing vitals, because we also want to know, okay, is this some sort of side effect maybe, related to the heart also. Are we having a dual, heart, cardiac issue and also central vascular issue that is a side effect of that? So we're looking for those other neurologic findings, vitals, and if those things are good, then we can feel at least a little bit more what's the word? Confident. I don't even want to use the word confident because I'm still not super comfortable with this, but we can be a little bit more confident that it's not like this immediate 911 thing that has to happen now. I still, from a safety perspective, especially in the type of care that I do, which is often one-on-one, I don't work with other people in a clinic space. So in this type of circumstance, if I'm not sure, I'm probably still calling 911. Are you thinking the same thing?
I'm thinking the same thing. I mean, you don't know how relieved I was when the other gym member that I know is actively working as a nurse walked into the door. I'm like, oh, thank God somebody else is here to just, be an extra set of hands, but also to bounce ideas off of like, you're seeing what I'm seeing. Like, this is weird, right? Like, I'm not overreacting. This is strange, especially because Kelly, the patient, was so calm and so normal. I'm like, I don't want to blow this out of proportion. I don't want to be responsible for giving her thousands of dollars of medical debt, but I also don't want her to have permanent deficits because I wasn't timely in calling 911.
Yeah. And I also, another thing too, so I'd always try to look at it from a lens of other healthcare professionals too. So if I'm an ER physician or an ER like triage nurse, and I'm receiving a patient like this, that's probably going to be stroke protocol until otherwise proven, or excuse me, until proven otherwise. And I just think that if it's me, I'm not willing to take the risk of, not following it up to rule out these other, major things. I'm personally not taking that call. Even if I were an ER physician, which I'm not, but even if I were, I don't know that I'd be comfortable taking that risk, because what do you just like, if they don't have any obvious neurologic deficits, like what if it's coming? What if it just like hasn't hit yet? So I'm just not, I'm not going to do that. I'm calling 911 on this case for sure. And then if it comes back that it's this transient global amnesia, then we can all like clap our hands and be like, great. And so the outcome or the long-term, let's look back at this paper for a second. So you agree on that? Like, I think we all agree 100%. That probably
I'm calling 911.
I'm calling 911 on this one. So especially to just have another set of eyes on it, getting an EMS team to take a look, they see strokes all the time, a lot more than we do. They see more of these emergent acute presentations than we do. So getting an EMS team to like do their whole thing, like that gives me a lot more peace of mind here. So interestingly enough, if we get to this, so this algorithm on paper, it is actually suggesting that if it says other focal neurologic findings, if yes, then you proceed to your other additional testing, your MRIs, your CT scans, your ECGs, EEGs, echocardiograms, depending on what the presentation looks like. And that's probably going to be done in the ED. And then it says, if no to meaning there are not other focal neurologic findings, then the next question is, do they have repeated episodes of short duration? If the answer is yes, then it's unlikely to be a TGA, and can you consider that transient epileptic amnesia? If no, then it's likely a TGA, and then you just kind of hang out. And then it says, so supportive treatment, reassurance, consider MRI in 12 to 24 hours.
It's a long time to just be hanging out.
It's a long time. I'm personally I am not comfortable with that. Now, if this patient was being managed, like if a neurologist was directly making these decisions, okay, great. But me personally, as a physical therapist, I'm not taking that risk. Like, I'm
not taking that risk for the patient, for their family, for myself.
Yeah.
And in the scenario that most of us are in, this patient drives to the clinic, or in
Yes.
this case, they're at the
Yes.
gym by themselves. And the article alludes to this. Supposedly, things like driving and eating and getting dressed and grooming, those are not affected because those are learned like physical behaviors that do not require short-term memory to do. So that's why maybe Kelly did drive to the gym during this episode. But the
And
last thing I'm going to say is, hey, go ahead, get in your car and go home and let's wait it out. Call me in six
because
hours.
what
There's
if
no
she
way.
what if she like ends up in Timbuktu because she doesn't remember
Right,
where she's driving?
right.
Like,
And then at one point, before I was like, man, I need to call 911. I was like, do I just put you in an Uber? Like, and do you go to urgent care? Do you go home? And so actually, at one point, after I had called 911, she decided, Kelly, the person with the transient global amnesia, called her partner. And her partner was obviously very concerned, but also happens to be a nurse. So there was a background of medical knowledge, which was great. But her partner also 100% agreed. Yes, you have to call 911. They have to get there because her partner was not aware of this prior episode. So even if I was like, man, this is transient global amnesia, Kelly wasn't obviously able to tell me in that moment that she had a prior episode. Her current partner didn't know she had a prior episode. So again, even more reason to say, this doesn't make sense. Let's call 911 and
yeah,
rule out a stroke or a TIA.
yeah, for sure. Yeah,
But
I'm
Kelly came in the next day with her partner and they were both like, thanks for your help. Here are some flowers. And she was like, I feel a little tired, but I feel totally normal. But she still, now a week later, still has not regained any memory of the episode. That's still
interesting.
blank. She remembers everything that people have since told her about the incident, but she has no actual memories of that about 12-hour time span. And for her, she was released from the hospital about 9 to 10 hours after I first saw her, and her memory still had not come back, but they didn't necessarily feel the need to keep her overnight, but they released her in the care of her partner, who's a nurse.
Right.
And she was like doing better, but the memory was still not back. She was released. She woke up the next morning and was tired, but back to normal.
Yeah. Okay. So then let's come back to the table one from this article, the diagnostic criteria for transient global amnesia. It has to be the anterograde amnesia. So it's not like you're losing your entire childhood of memories. You're basically limited to, the day in which it's happening. And the moments surrounding it. Oh, what did I just say? Did I even just say anything? So anterograde amnesia must occur during the episode. Cognitive impairment is limited to amnesia, which is why she was totally fine otherwise, other than forgetting what day it is and what is happening and what she just said and what you just said and who she saw and where she went. But that's still really scary. Episode must resolve within 24 hours. So in order for it to actually be considered this TGA, it has to be resolved within 24 hours. It can be resolved earlier than that, but not necessarily. Episode must be witnessed by a reliable witness. No clouding of the consciousness or loss of personal identity occurs. So did you ask her, like, does she know her name? Like, does she know?
She
Okay.
knew. And what was funny about that is she was so proud of it. She's like, I do know the answer to that question. And she like yelled out her full name, including her middle name.
Yeah.
And then when I was on hold with 911, they're like, well, how old is she? I was like, oh, 50s. And she's like, oh, that's so nice of you. She's like, but my actual birth date is this, and I'm 59 years old. So she still had this like sense of humor, which was interesting.
Which goes along with the cognitive impairment is only limited to the amnesia component. And then no focal neurologic signs or symptoms occur and no occurrence of recent head injury, no active seizure. So that's the diagnostic criteria. Now, the prevalence of this, I mean, it's pretty rare, especially in younger people. The prevalence increases a little bit in older, but it is so 8 cases per 100,000. But then when you get to people age 50 and over, it's 23.8 cases per 100,000, which still like that's pretty rare. But given that you just had this happen to you, and I had a patient a week before that mentioned it, I thought we should do an episode about it because you and I had never really heard of it before.
Yeah, it is interesting once it kind of comes to the forefront. My guess is I've had patients with this before, and
Yeah.
it didn't come up in their medical history. They didn't think to check the box. I didn't question it deeply enough for it to come out. But I can say with confidence that this is the first time that I've witnessed it firsthand.
Yeah,
And
and I would be terrified.
strange.
I would be super terrified. Like I would definitely be thinking along the lines that you were, if I saw that. So let's talk prognosis. So prognosis of transient global amnesia is pretty good. The population-based studies don't demonstrate any increased risk of cerebrovascular accident again, because this is not characterized or associated with vascular ill health or anything like that. Although the pathophysiology in this paper is interesting because there was almost like a transient lack of venous drainage of the hippocampus. But again, that's not necessarily associated with poor blood flow or, a hemorrhage type, like oh my gosh, what is the word I'm looking for? Like an aneurysm type thing. It's not associated with any of those risk factors. So there's no increased risk of that. And then that's pretty much it.
The one
Most
thing that
initial
the
episodes
paper
are, go ahead.
Well, the one thing that the paper does potentially suggest as a precipitating event is something emotional happening, either positive or negative.
Mhm.
And for Kelly, there was something that was happening. Her dog was very ill, and there was some stress associated with that potentially could have been a precipitating, stressful, emotional event as a trigger. And the other thing was she was working out for about 60 to 90 minutes beforehand. Now she's not lifting in a way where she's specifically using the Valsalva maneuver, but maybe she wasn't breathing properly. And I think if we go down that road as a potential cause, that gets a little bit scary because I'm encouraging a lot of my patients, young and old, to lift regularly and lift heavy.
Yeah.
And if that's seen as a potential precipitating factor for this event, that is concerning in terms of what I'm recommending.
I totally get where you're coming from. So going back to the paper, most frequently cited precipitating events include acute illness, so something viral, which we talked about this in I did a student panel for LSU, and we talked about viral presentations of joint pain or neuropathies. There's a lot of viruses that induce these types of things. So acute illness, medical procedures, so having something done, maybe being exposed to anesthesia, those types of things, significant physical exertion, sexual intercourse, high altitude environment, especially if you're not used to it, extreme temperatures, and Valsalva maneuver triggering emotional events that are either positive or negative. So, and I have a sidebar on that in a second. Or other, things like birth announcements, news of a suicide, something really bad in the news, things like that. So anything that sort of like bounces your sympathetic nervous system into gear or has some sort of like underlying systemic, virus or something circulating in your blood that, maybe your blood and your brain doesn't like. So I don't think though, so because of how rare it is, and that because of the relatively low incidence, it wouldn't preclude me from from suggesting people of all ages to participate in resistance exercise, because we know that even now resistance exercise, and I want to cover this in another topic too, but I'm having a lot of trouble with my own like word formation today. I promise I'm not having a stroke or a TGA episode. I'm just a little tired because I haven't like slept well in 2 days. But what were we just talking about? I've done this before in podcasts.
Right. We recommend vigorous exercise because we know it's so beneficial in so many factors, right?
Yes.
Bone health, tendon health, muscle health, cardiovascular health, reducing the risk of stroke, reducing diabetes,
I remember what I was going to say.
Cholesterol.
The blood pressure. So we know that even isometric exercise actually has some of the best blood pressure, which was totally, all of these studies are like, wait, really? We all thought that Valsalva and isometric exercise were associated with worsening blood pressure, but we're actually seeing the opposite. So we know that these things, that resistance exercise is beneficial across the board for all cause mortality, and especially resistance combined with some aerobic exercise. So it wouldn't preclude me from that. But the one thing that it does say is a history of migraine headache is the only diagnosis that's definitively associated with TGA, with relative risk of 5.9. So that's not that, even that relative risk is not, it's not shouting from the rooftops. So if you had a patient with a history of migraine headaches and they're over the age of 50, maybe this is something that if you ever saw it and they didn't have any of those other cardiovascular risk factors that would be associated with stroke, then it might clue you into, okay, this might be a TGA. But still, like we were discussing before, neither Jess nor I want to take that risk.
Very true.
So yeah. All right. So have we talked this one out? Is there anything else?
I think the great thing is that as bizarre and concerned as I was initially interacting with Kelly, the outcome is great, right? Like you send somebody away in the ambulance and you don't know what's going to happen. And I'm really grateful that her partner called me later that day. And then also Kelly, I saw her alive and well the next day, and I've seen her multiple times since. Like, this is something that you don't die from. This is something you don't have permanent deficits from. Like, this is the diagnosis that we want when somebody is potentially presenting like a stroke, but they don't have any neuro findings. Like, this is what we hope for.
Yeah. And it's way more scary it seems like it's way more scary for everybody that's witnessing it. And not so scary for the person that's experiencing it because they don't know what's going on.
Well, just like Kelly got scared for, a minute or two and then forgot that she should be scared about it, which was great because it kept her very calm, kept her sense of humor up, and she was very compliant. Like, oh, I'm going to get up on this gurney right now. Okay, bye everyone, waving to the gym type of thing. So.
All right. Well, I think that we can probably close this one out. So transient global amnesia, if you've never heard of it, you know of it now. I will put the citation for this paper in the show notes. It's just a really nice, like 3-4 page overview of what this condition is and differentials and how to evaluate it. But me personally, I'm not really following their algorithm, because even if I don't see neurologic deficits, I don't want to take that acute responsibility for not being fast enough in the event if it was a stroke. So thank you. I think next topics, I really want to do an episode on heart rate variability, because that is something I've been researching a lot and looking into a lot. And I think it's really cool and very promising for a lot of conditions. Heart rate variability and isometric exercise for blood pressure management. What topics are there? Anything that interests you that you want to cover in the next couple months or so?
Oh man, I feel like there's infinite options out there.
There really are.
Coming back to the basics of why is lifting so important and what constitutes heavy lifting to make those differences in bone density, bone mass, tendon resiliency? What constitutes enough or intense cardio to make a difference to have those health benefits? Like all of these simple things, even that we already know and are floating around people's minds, but maybe they don't know the research behind it, or there's an element of how do you even get started with it? And how do I make this part of my life? And what is enough objectively in creating a structure to really help people be successful with it?
Yes, all things. If y'all have any topics that you want to hear me and Jess or others talk about, you can reach out to us on social media at Redefine Health Ed, or on X, which I can't get used to, at Redefine Con Ed, or you can email me info@redefinehealthed.com. Also, be on the lookout for our new website. It is, by the time I publish this, it better darn be published. I've been having all sorts of trouble with that, but take a look at our new website, redefinehealthed.com, and check out our mentorship options. We have a whole new formal mentorship program. It can be customized to you, and there may be CEUs. There are certain states that will allow for formal mentorship opportunities to count for CEUs. So we can make that happen. And it can be anything sort of clinical. It can be getting a primary care PT program started, or just learning how to build it into your regular existing practice. So thank you for joining me and Jess on the Primary Care PT podcast. We'll be back in a couple of weeks. And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPTPodcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.